Hello, and thank you for joining us. This is Beth Ziefert with World Class CME, and I would like to welcome you to our COVID-19 Breast Imaging Impacts, Challenges, and Opportunities webinar. World Class CME would like to thank GE Healthcare, the BREM Foundation, and Volpara Solutions for supporting this webinar. Now I would like to introduce you to our speakers. Our moderator is Dr. Saini, coming to us from New Zealand. She is a senior breast radiologist at Hutt Hospital and chief medical officer of Volpara Solutions. Our panelists today are Dr. Rachel Brem, who is professor and vice chair of radiology at George Washington University and the founder and chief medical officer of the BREM Foundation. And also with us today is Phyllis Falk, who is the CFO and practice administrator for Imaging for Women in Kansas City, Missouri. Please give a warm welcome to Dr. Saini, Dr. Brem, and Phyllis Falk. Welcome.
Hi, everyone. Thank you for joining this webinar we're doing today on COVID-19 breast imaging impact, challenges, and opportunities. I have some wonderful speakers here with me. I'm Dr. Monica Sani, and I am a breast radiologist, and I'm also the Chief Medical Officer for Volpara Solutions. I'm going to first introduce Dr. Rachel Brem, who's at George Washington University and the founder of the BREM Foundation. Dr. Brem, thanks for joining us.
It's a pleasure. Thank you.
And we're still working on audio for Phyllis Falk, who is basically the office manager and administrator at Imaging Associates, who will be joining us as well. So we're going to go ahead and start with some questions. And if you have any questions, you can, of course, use the poll everywhere and put in your questions and we'll answer them as we go. And we'll also make sure that we're able to cover some questions at the end. Hi, Phyllis. Can you hear us now? We're getting there.
Hello.
Hi.
Hello. Can you all hear me? Great.
We can. We're excited to hear from you. So starting off, Dr. Brem, I'm going to start with you. There's been many different society recommendations of what to do during COVID. The Society of Breast Imaging, the American College of Radiology, and some of that has had to vary, of course, from those recommendations depending on where you live. So we were just wondering what you're anticipating as far as the impact to your staff and how you're protecting them through the COVID crisis.
So thank you for that question. I think that there have been a number of different recommendations from different societies, but I think what they've all said is that it really depends on where you are. The variability in the country is so marked. So I'm in Washington, D.C. We are now the fastest growing COVID area in the country. We have sort of plateaued, but we're still certainly in the thick of things. And although Maryland, our neighboring state, has come off, has relaxed some of the regulations, we have not in DC. So we are seeing patients, and the way we protect both our patients and our staff is that there is a requirement for every patient to wear a mask. We don't allow patients to bring support people with them. It's only them at this point. All of our staff wear masks, and we have N95 masks for our staff that are doing biopsies. We are only doing biopsies and diagnostics. We are not doing any screens, and it's really important to continue doing biopsies because the women with breast cancer are now getting treated with cancer modulating therapies like hormone replacement therapy or Herceptin for those that have appropriate receptors. Every patient is screened before they come in. Every staff is screened before they come in for their temperature and any potential symptoms. And the other thing that we've been doing is not all of our staff is ever in at the same time. So we rotate, and we rotate with the same staff so that if anybody is exposed, and if anybody is ill with COVID, and I actually had COVID in early March, I was one of the earliest in our area. It shut down breast imaging for 10 days. We learned a lot from that. But I think what we are doing now is doing everything we can to protect both the patients and the staff. And the other thing that we're doing is we're absolutely minimizing any touch points with other people. So the patient goes into the mammography room, they change in there, they have their studies in there, the images are reviewed by the physician, any additional imaging is done while the patient's still in the room. And we are we are doing as many same-day biopsies as we can. So we're trying to protect our staff as well as our patients, and our volume is, of course, a small fraction of what it used to be.
Yes, thanks so much, Dr. Brem. Phyllis, can you kind of give us an idea for your practice, what you guys are doing? Are you doing screening? Are you doing similar things? Have you broken out into teams like Dr. Brem had discussed? What's normal for you guys at this time?
Many of the things Dr. Brem is doing, we are also doing at Imaging for Women. We are in a different part of the country, so not a hot spot. I'm thankful for that. However, we have conflicting rules depending on county, city, and they're very far apart. So it's been very confusing for our patients and us. We just had a soft reopening. We are just starting to see those patients that are demanding screening right now. But like Dr. Brem, every patient must wear a mask in the office. We have in-car check-in that we are implementing in our office. So the patient lets us know when they're here. We let them know when they may enter our facility. The other thing we're doing is rotating our staff, just like Dr. Brem and her staff are doing. We are a small center, and luckily our workflow allows for those patients who are immune compromised or older in age to be put in a separate side of the office so that we can separate them, and we're thankful for that. Every patient that checks in is immediately put into what we call a vacation destination or a dressing room, and that is theirs until the end of their visit with us, at which time it is completely sterilized and gone through before the next patient can be admitted into that room. So if there is, we are not allowing visitors, only if, in rare circumstances with perhaps a physically disabled person. And then, of course, they have to have their temperature taken when they enter our office. All staff is screened twice a day for temperature and any signs or symptoms. And so far, we have been very fortunate. It has not entered our office.
And Phyllis, for everyone out there, just tell them where your center is, because I didn't get a chance to introduce you and say that, so they have an idea of where you are in the country.
So we're located in Kansas City, Missouri. For those that know the area, we are north of the area, and we are a small center in a freestanding situation.
Great, excellent. And for both of you, the next question I kind of want to talk about, you've already covered about social distancing, how you're dealing with that. But I guess the other question is, what's the impact, and the potential delayed spike or the spike in delayed diagnosis? I'll ask Dr. Brem if she could answer that for us.
Of course. So there was a study that was just released by Epic, the electronic patient record system, that has shown that screening, all kinds of screening, mammography, colon cancer, is down 84 to 96%. We have absolutely no screening. And we are doing all diagnostic patients, all patients who are B0s from screenings prior to COVID. And we are doing biopsies, as I mentioned before. But the impact is really significant, and we all worry, we talk about the risk benefit of having a screening examination and exposure to the patient and to the healthcare provider, and trying to find that right balance. And it felt comfortable in March and April, and is beginning to feel a whole lot less comfortable in May. When we're talking about a 4-week delay, it's very different when we're talking about a 3-month delay. So we are beginning to worry about what the impact is. At our institution, we were doing only level 3 breast cancer surgery. We are now opening it up to 2A, B, and C. And at our multidisciplinary conference, everybody works together to triage which patients need surgery most. And so there is no autologous reconstruction at this point. We are beginning to do mastectomies with implant reconstruction because of the delay. And the other thing for us is that we don't believe that our maximum surge, hopefully we won't have one, but the largest numbers won't be until the summer. So probably June, maybe early July. And so we have to deal with the breast cancer situation now. We have made such great strides in decreasing the death rate from breast cancer. And how much headway are we going to lose? And there's no question that we are going to miss some boats about, we are going to lose the opportunity to find the earliest, most curable breast cancer. But our hope is that with the additional technology that we have, that the impact is really not going to be that significant. And we don't know if it's true. It's a research opportunity that many of us will look at. But we are, as comfortable as this felt in March, it is feeling extremely uncomfortable at this point. I am trying very hard to get approval to start screening high-risk women with MR, and even that is not being embraced by our administration. Although we are blessed with plenty of PPE, our ICUs are full. There's an enormous blood shortage. So we have to think of all the downstream impact of breast cancer surgery. But we are opening up, that we're weighing this delay with the urgency of seeing increasing patients. And we look forward to beginning to, although we never really closed except for that 10-day period, we are trying to triage what patients need to be seen, how soon they need to be seen, and worry about the impact for all the incredible mortality reduction that we've seen and how this is going to impact that.
Sure. And actually, before we move on to the next question, we got a question from a viewer that said, what type of PPE besides masks are mammo and ultrasound techs wearing? I'll start with you, Phyllis, and then I'll have you, Dr. Brem. You did kind of touch upon it earlier, but people want to know what you, because I'm sure center to center, what you may have available may be different.
So here, all of our frontline staff, including our front desk, are wearing N95s. And then for any procedure, they are also equipped with the face shield. So of course they all have gloves, etc. But that's about all we can get our hands on here.
Well, that's a lot. So at our institution, everybody has an N95 mask. They're not required to use them just for mammograms. They are required to use them for biopsies. And we are again fortunate at our institution that testing is rather plentiful. So every patient admitted to our hospital is tested, and we have the opportunity to request testing the day prior to any biopsy that's scheduled. The caveat to that is that we're doing a lot of same-day biopsies. We're, again, trying to minimize the touch points. So we have not really used that extensively, but we do have the opportunity to have patients tested prior to a biopsy, because we know there are so many asymptomatic carriers. So we also used disposable isolation gowns during biopsies, eye coverings, N95 masks. We have actually all moved to wearing scrubs. I ordered scrubs for everybody. I think in the 35 years that I've been practicing, I've never worn scrubs to a breast center, but things definitely change, and that way we can come in our own clothing, leave in our own clothing, and leave our scrubs at work where they're cleaned for us. So same thing, of course, with white coats. And gloves are everywhere, wipes are everywhere. After every patient, we're deep cleaning every room, every surface. We don't call it a vacation destination, but I like that. And we do have private rooms with doors for people to change in, and that's where they'll be waiting. So there really is nobody waiting in our waiting room. Everybody has their own individual space, either in our dressing rooms or in our multiple sub-waiting rooms. So there's no more than one patient in any waiting room. So that is how we try to, but we do have to reuse our N95 masks. We reuse them until they're soiled. Many of us, myself included, put a surgical mask on top of our N95 so that when we are in contact with patient, if it does get droplets, it's a whole lot easier to change the surgical mask than it is to change an N95 mask.
So there was a question, did you guys, and Phyllis, this might be more applicable to your center, did you guys get fitted for the N95 masks? Because that's the big thing, is having the mask fit properly. And I think we're really relearning universal precautions all over again, but yet to the nth degree. So Phyllis, was that something that was available to your center to have them fitted?
We are not able to get small, medium, large. So unfortunately, we did do in-house fittings to the best of our ability with what the supply was that we could get.
So at our institution, we
makes sense.
have the hood that people put an N95 on. You put a hood on and they aerosolize sweet. It's actually saccharin until you can feel, but until you can no longer taste it. But the issue is that there really aren't that many sizes. They're small. Very few people are smalls and very few people are extra larges. So most people are the standard size, but we do, I personally was worried about the reusing of the hood, particularly with the limitations of the size of masks, but we were all fitted with those hoods.
Yeah. Well, I think we all have to make do with what resources we have, and we have to be flexible, or agile, as the word is used in business, to do the best we can for patients. And thinking about that, we talked about the delay in diagnosis, but it'd be interesting to know too, what's the revenue impact to your center? Phyllis, I'll kind of start with you. And how do you plan to recover that lost revenue?
As Dr. Brem said, our immediate loss was at 80%. And, we were able to continue doing diagnostic studies at our center. As a matter of fact, we were requested to continue to do diagnostic studies to keep the patients out of the hospital. So we were grateful for what little business we were able to continue during that time. But yes, the immediate downfall in revenue from day one, and I have not missed a day of work since this all started. And that's what I do, is the constant data mining. We did climb on early for the PPP program and the advanced Medicare payments and what was available through those items, and grateful for that. And we are very grateful that we were able to have a soft opening this week so that we can minimize that. But to prepare for, hopefully the months that we all can enjoy the warmer weather and maybe a very flattened curve, we are hoping, to extend hours and things to get these patients in while we can before a year goes by for these women. That's what our concern really is what happens a year later if the cancer is there this year.
Right.
So more than the revenue, that is our concern.
So it sounds like you guys may be talking about also different hours once COVID levels come down or the concern level comes down. And actually, for this question is for both of you. Will you be trying to do additional hours, weekends, evenings, hours that may have been outside of what your normal schedule was, to try to make up that volume?
I think it's a two-part question. One is, we plan on doing diagnostics during the day, screens at nights and weekends, have certain hours for elderly, or immunocompromised as the supermarkets do, to try to be even more vigilant maybe at the beginning of the day. But the other thing is, when are women going to feel comfortable coming back? And there was a study that showed, that recently was released, a survey that was done, that half of the women said that they wouldn't come back for a mammogram in May because of their concern for COVID. And that by August, two-thirds said, they said two-thirds said that they would. But I think the other thing that we learned from that survey is that women are not gonna, we not only have to open our hours, but we have to make them feel safe and comfortable. If we open our hours and they don't feel safe and comfortable, you're not gonna be recouping that lost patient care. And I'll agree with you, it's patient care more than revenue. So you have to do whatever you can, whether that is using social media or letters to patient, explaining what you're doing. They want patients want minimal contact with other people. They want to be assured that there's deep cleaning between every time a room is used. They want to make sure that there's adequate PPE, that the staff and the other patients are getting tested or going through a questionnaire and temperature testing. So I think if we just think about opening up the hours and that the floodgates are going to open, particularly with so many recommendations that biennial mammography is sufficient. And you can easily see women saying to themselves, well, gee, you know, the American College of Family Physicians says come every 2 years. I'm going to use this opportunity to not come now. So I think, you know, we are all going to be opening hours. We are going to be extending we'll probably have physicians there for at least 12 hours a day in 2 shifts. We'll be doing screening nights and weekends. And the good thing is that our techs want to work more hours because they have been not furloughed, but less hours. So they're happy to make that up. So that's a wonderful thing. But if we all believe that you just open the door and the floodgates are going to happen, it's not going to happen. You need to use social media to communicate with your patients, with your referring physicians, to make sure that they understand what precautions you have taken, that you do have enough PPE for your staff, for your patients. And I think that we have to be careful and vigilant, not just to say, well, my hours are going to be open, but how am I going to get the messaging out? Have probably information as patients come in to try to decrease their anxiety. But I think we need to have a campaign, a marketing campaign, so that patients know that it is safe to come for their mammograms, because right now that's not an accepted thing. And we will open, but you know, for those people who are on this webinar, don't forget to think about what you need to do to make the patients comfortable enough to come in to get their screening.
And it sounds like there's a question from one of the viewers asking about, are you cutting out, or I think what they mean is, are you triaging based on age and increased COVID risk? So someone says, do you recommend cutting an age group out? You know, our clinic is considering people over 65 who might be at greater COVID risk. Should we consider delaying them or postponing them? And from what I'm hearing from both of you, from Phyllis, it sounds like you have a separate area that you're trying to help the immunocompromised, so you're not triaging based on those. Dr. Brem, it sounds like it's similar. You're doing sort of similar things, but you're not telling people, you're not triaging based on age or some other factor unless they answer positive on the COVID questionnaire that they may have active COVID symptoms. Am I understanding that correctly?
Right. I mean, we know research has shown us that the elderly women who are treated less aggressively and screened less aggressively die of breast cancer. So
Yeah.
I think we have to remember that. And we are not open for screening yet, but when we are open for screening, we will not, we will triage by need, but not deny screening by age.
Right. And, you know, there was another question asking about MRI for high-risk patients. Since we're not doing screening, the question is, should we be doing MRI? Or, you know, if we're not doing screening mammography for the high-risk patients, should we be going down that? And it sounded like earlier you were saying that that is something you are trying to resurrect, is to get the MRI for high-risk patients. Is that correct?
I think these are very anxious, extremely high risk, greater than 20% lifetime risk. I think if it were my choice, I would definitely open that up, because I think we're looking at young women with triple negative breast cancers, aggressive breast cancers. These are the ones that 3 or 4 month delay could make a substantial difference. I'm not worried about the 4mm DCISs in an 80-year-old woman, but I am extremely worried about young women with BRCA mutations and P53 mutations. And I think we don't know how long this is going to go on. I mean, what's the threshold? So I would very much like to see us being able to do that. And I think in this population, it's much more effective than mammography. So, you know, I am hopeful that if we had had this webinar in a few weeks, I'd be able to tell you that we are doing high risk screening. I know our medical oncologists are calling me with their very high risk patients, particularly their young patients that are really having trouble with waiting. So my guidance would be that particularly if you're not in a hotspot like we are, and if your administration allows you to open up for high risk screens, then I think that's where we should start.
Yeah, absolutely. You touched upon social media earlier. Could you elaborate a little bit more of what type of social media you're using? Are you guys doing calls, referring physician letters? What all does that involve for your site?
So for our, I mean, I don't know, Phyllis, I don't know if you want to, or I'm happy to.
It doesn't matter. Go ahead, Dr. Brim, and I'll go after you.
Yeah, I think many of our electronic medical records have ways of sending messages to our referring physicians. Also, we have something called Follow My Health. You know, Epic has my chart. I think we can use those to send. I think those are very effective ways to send messages out to our patients. Not only that you're open for whatever it is you're open for, but what you are doing to allay their fear and to decrease their risk of COVID. What additional steps you've taken to assure their safety. And so I think that that's really important. I think also using, you know, the typical social media, the Facebook page of your center, or, you know, certainly at the Brem Foundation, we have done a great deal to talk about, you know, the appropriateness of delaying screening for right now. We're talking about the need to open up in the near future, and talking about empowering women, which is a big fundamental principle of the Brem Foundation, that if they feel something's wrong, nobody knows you as well as you know you. And if you feel something's wrong, even in the time of COVID, you need to call your doctor, come and see come and see the physician. So that's, I think, every social media platform that your center is with, but don't forget to use your electronic patient record, both to your referring physician and to your patients.
Oh, I think that's an excellent point. Phyllis, how about you at your site? What are you guys using?
Similar approaches, and we are also we have developed something for our referring physicians to hand to their patients to let them know what we are doing to keep them safe, because we agree with Dr. Brum. If the patient does not feel safe, they are not going to return. And to get the screening patients back in, any patient who was rescheduled or canceled their appointment when this started, automatically in our EMR, we set up a data mining list so that it falls to that list so that we can reach out to them personally. And we have a whole team of people, you know, we're repurposing people right now, and we have them reaching out to them, checking on them. How are you doing? Do you feel safe scheduling in July? Do you have any questions? Are you having any problems? So we're touching base with them, even if they're not scheduling yet.
Yeah, I think that's really important. And I think, Dr. Brem, you pointed out something that people may not have realized of using your electronic medical record, the resources that are right in front of you beyond just your Facebook page and other things, that if you can use that and basically capitalize on that so that people can get the message out. And more importantly, like you said, if someone has a problem right now, we need to make sure those women are getting in and being seen either by their personal physician and then being referred to us, but that they shouldn't have to wait for those. And it's a trying time, right? Some certain views have come in. There's one from Seattle, Washington, who said they're in a similar situation with limited precautions. Another person at a different site said that they just opened back up for screening and they have completely filled up. And I think it's it's completely variable depending on where you live and what resources you have. You know, and thinking about different ways to make sure that women get in, you guys have really touched upon all the different ways to reach out to patients. And there's no way to predict when this will end. And I think region by region, we'll have to sort of take it as it is. It's, you know, interesting to hear your perspectives. I, of course, live in New Zealand, so we have a very different way of how things are going. We shut down for 4 weeks and we've just recently reopened. But we, because we're a public health screening and a very different model than the US, we did triage patients based on what we think were the people who would be most at risk for COVID, and age was a factor that we used. And some patients, you call them and ask them to come in, as you said, and you talk about whether they're comfortable. And some may say, you know, I can wait, I'm okay. But it's important that they know that they have the option, especially if they have an ongoing problem, that we don't want them to wait or to delay. And that's an area of concern, as you said, with people just not even coming in to their physicians to let them know that they have a problem. So then the second step is to getting to be seen by us. So definitely challenges in this time. Do either of you have comments you want to make or additional things that we haven't covered that you think would be important for the viewers out there to consider in their practice? I'll start with you, Phyllis.
Well, I think it's very important to let the patient know, and you know, we all have to change our workflows. I think that was the most difficult thing for my staff when they returned, but reminding them of why they're wearing the mask, reminding them to, you know, the protocols weren't written to sit in a book. The protocols are written to help us practice as safely as possible under a situation that nobody anticipated happening. Certainly I didn't in my career. I was kind of hoping I'd get to retirement before any of this happened. But, you know, I think it's really important to understand that the patient already has anxiety dealing with COVID, and what that has brought into their home, because it looks different for every patient, depending on their age, depending on what their family life is. And so they're dealing with that. And now they're coming in for their mammogram, be it screening, be it diagnostic. In the back of every woman's mind is, oh, I hope I have a negative exam today. And if it is not negative, be prepared to change your workflow a little bit. You know, here at Imaging for Women, we take them to the next step. If the patient needs a whole breast ultrasound because she's C or D, do it today. If the patient needs a handheld, do it today. Or as Dr. Brim said, get them all the way to biopsy today. It is a change of workflow, but it is certainly a time where maybe your numbers are down, and this is a possible change that we can all look at. And I think it's important. It lowers the anxiety and it lowers some of the risk factors that are not being talked about, you know, outside of the realm of risk cancer for breast cancer or risk assessment for breast cancer. We're talking about the patient's overall health now. And I think anxiety is a huge part of what we're dealing with in breast centers right now.
And I think that's all very true. And I would add to that, for those of you who are thinking about reopening, think it through very carefully in terms of workflow. Your workflow is absolutely going to be different. And I think, you know, we're all familiar enough with our workflow to think about, you know, we are in an urban center, but there are those that are in rural or suburban centers where there's a parking lot. You know, it's wonderful to have all patients pre-register so they don't have to stop at the front desk. Many places that can are having patients wait in their cars. I mean, at our institution, we really can't do that. We don't have a parking lot. You know, we're on the 8th floor of a 13th floor building, so we can't do that. But I think it's really important to walk through each step. How are you going to deep clean each room after every patient? Where is the patient going to wait? How are you going to minimize the contact? And everybody should really think about that for their centers. And what else? What are the little things that are going to make a big difference? And things as simple as giving a patient a bag for their belongings that they can take with them so they don't have to put them in a locker. Those are the kind of things that could really really optimize a patient's security and feeling of safety. But I think, and the other thing is that you are not going to be able to do the same number of patients. Many places who are doing screening mammograms in 15 minutes, most of my colleagues that I've spoken to are allotting a half an hour because patients are staying in the room and it is requiring deep cleaning. So the way you're going to be able to get the volume that you had before are things like longer hours, but more spacing of appointments. And don't forget about things like ABUS. That could be a really significant same day patient care advantage and significant impact on the revenue stream as well. So I think everything is different and nothing's going to be the same for a very long time in any aspect of our lives and certainly our practices. So I would say, maybe have a committee and have everybody think through each individual step of the patient coming in at your center. If I could, I would love to have patients waiting in the car. That's just not going to work for us, but we're very fortunate that we have very large dressing rooms with doors that can really function as individualized waiting rooms. So I think thinking about it, really planning it out is going to be the most successful way to reopen. And I'm thrilled to hear that whoever wrote that question, opened up for screening and is filled, because I think that's terrific in terms of patient care, of our practices, all different aspects of it. So, we hope that when we open up for screening that'll happen as well. But I think people should expect to generally open up in a stepwise fashion. So we're hoping to open up with screening for high-risk women and then further triage of screening until we just open the floodgates.
And Dr. Brim, we had a soft opening here, and I will tell you, we were flooded with calls. And I did not anticipate that. I thought it would be a slow ramp up. And so that required immediate action. And luckily, as a committee, we thought about what if that happens, not that we think it will. And so our team was better prepared to handle that entourage that we were not expecting on day 2 of our soft opening. We found that women here in Kansas City, they're going to be going back to their jobs and they didn't want to miss their mammogram. And so they wanted to get in prior to going back to their jobs. And like you, I thought it would be a very, very slow process. So prepare for the worst. Hope for the best, prepare for the worst, is what we all have to do right now. And it looks different for every center. I've spoken to many of my colleagues, and everybody is doing the very best they can. But once you do write your protocols, once you roll your protocols out, I strongly suggest for practice administrators and those supervisors of your frontline people, walk around, check on your team, make sure they're okay, because it's a big pressure, and their lives at home have changed also, as well as our patients, and it all has to work together. So walk around, make sure that your protocols are being followed, because it's not that the staff wants to be sloppy, they may forget, and we can't afford to forget right now.
Right. Excellent points. There's been a number of questions I want to make sure that we get through, and you've answered a few of them about how you're spacing out your appointments. You both talked about supplemental screening. Dr. Brum, you mentioned ABUS, automated breast ultrasound, and Phyllis, you did as well. It seems like you're saying that patients are pretty amenable to just get it all done while they're there. and not return. Am I hearing that correctly?
Yes, I
That's
mean, I
what
think,
we are seeing.
Yeah.
and it
Okay.
goes beyond that. You know, if they they have a diagnostic mammogram and they need an ultrasound, we're trying to do same-day biopsies, trying to minimize the number of times. And in fact, our MR schedule is pretty light because we aren't doing the surveillance that we normally do. So we'll even try to add on same-day MRs. It's in our center. So anything you can do to minimize the number of time a patient has to return is beneficial.
There's a question here I'm going to relay, and I'm hoping this person might give us clarification. So the question is, do you foresee increase in biopsy rates in less B3 cases, since we haven't seen a particular patient for 3 to 4 months? I'm not sure if that might need a little bit more clarification, if that makes sense to one of you.
I think we will still I think we will still use the same criteria to decide if somebody needs a biopsy. I think what we will see is hopefully not, but the concern is we'll see more larger cancers. I don't think we should change the criteria that we use to recommend biopsy. You know, B3 is B3, but the question is how many cancers are we going to find that are larger than we would have found earlier. But I don't think we should be changing, you know, the BI-RADS criteria. I don't think we should be changing how we recommend biopsies. Obviously, the fear is that there will be more advanced lesions.
Correct. And so there's another question I'd like to ask both of you. So one viewer put in, are you fearful that many sites will go back to one-size-fits-all mammogram at this time because that's the most expeditious and not provide personalized care? Phyllis, I'll let you answer that first, and then Dr. Brem.
Oh, I hope not. Certainly that is not what will happen at our facility. I would rather retire and end my days in my career before I saw that happen. I think that would be 10 steps back for all of the hard work and effort that those of us who love what we do. I certainly hope that doesn't happen. That would be my hope. I don't know. I don't have the crystal ball there, but I hope we are stronger than that.
I think what Phyllis said is true, but I do think we're going to be doing things differently. We do things differently now. We used to have every patient come into our reading room, show them their images, and give them their results. We are not doing that anymore. The patient stays in their mammo unit, in their mammo room. We still give the diagnostic patient their results, but we stand at the door and speak to them. If it's normal, we'll tell the technologist that to please relay that. We've never done that before. And we used to have every patient sign their BI-RADS letter, and we don't do that anymore to decrease the contact. So I don't think it's less personalized care. I think it's adaptive care to the time of COVID. I hope we go back to the time where we do bring every patient into our little very intimate diagnostic reading room, but right now we just can't do that. So I think I have friends who have had, you know, practices like yours, Phyllis, very beautiful boutique practices that they used to have same-day read screens, and they're not doing that anymore because it will minimize the amount of time, not so much for patient flow, but to minimize the amount of time that the patient is in the center. So I don't think we'll be less personal. I don't think we'll be doing lower level care, but I think our care is going to look different for the foreseeable future.
Yeah, absolutely. I think as you put it well, adaptive screening. And there's another question that kind of came similar to that is, will risk stratification change for patients? Dr. Brem, what do you think?
I still think we're going to use the tools that we need to use to optimize the detection of early curable breast cancer. And, you know, we are so fortunate that we have many tools. I mean, you know, that is one of the fundamental principles of the Brem Foundation, and so many states, and now a federal bill about breast density. So are we not going to be doing screening ultrasound in women with dense breasts? No, we are going to be doing screening ultrasound. That is optimal care, and that train gratefully has left the station and isn't going back. I think we're still going to be using MRI for high risk screens. So I think we still will be doing risk-based stratification as we did before, but I think we will think about abbreviated MR protocols more, perhaps. Certainly a recent paper just came out that really supports that. So I think that we will be looking at ways to minimize the amount of time that patients are in. But no, we will be doing risk-based screening.
And so there's another question about one site says they've seen a recent uptick in COVID positive patients who are coming out of quarantine. Do you think there's a role for rapid COVID testing? Phyllis, I'll ask you first.
I do think there's a role for it. And I think depending on where you are, in our country or in the world, I think depends on how available it is.
And Rachel,
So,
I think you were mentioning that you guys were doing some type of testing on staff. Was I hearing that correctly?
So, yes, but more so, I think when we ramp up back to normal, whatever that means, levels, staff will get tested just as patients will get tested. I don't think we're going to be opening up, it's not if they're going to get tested. Staff will get tested. It's how often. I mean, if you're negative today, when do you need your test again? If at the hospital, every inpatient gets tested and it's good for 5 days. Are we going to? So we don't have the answer to that. We have a great deal of brain power looking at that, but I think it's part of safety for our patients, patient comfort and perceived safety. And I think now with rapid testing, for us, particularly in a hot spot in the country, going back to routine testing is going to involve staff testing as well. The exact recipe for which is not worked out yet.
Yeah. So someone clarified on that earlier question about the B3. So I think what they're asking is, are you more likely to biopsy a patient rather than give it a BI-RADS3 and a follow-up, given the current situation? Which that is an interesting question.
So right now we're doing a little bit of the opposite. If they're a 5-round calcification in an 80-year-old, we'll B3 that, right? And we might have in the past, but I think our threshold for B3 and holding off on 4A is greater because of the state of the way things are or were. As we're beginning to open up, I don't think we should be biopsying more B3s because of COVID. I think you need to practice best practice, and that doesn't change. We sort of modified everything we did when COVID first came to be. So we have a pretty low threshold for recommending biopsy in our institution as well. We're in DC. Up until recently, we had the highest death rate for breast cancer in the country. We're now number 3. So, and at our institution, we do a pretty good job of finding early cancer. So our threshold for biopsy is pretty low, appropriate, but with the prevalence of disease being as high as it is. But I do think practice the best medicine regardless. And so B3s are B3s.
Yeah. But it is an interesting time. I think it was a poignant question because it
Yes.
does force us to start making decisions. Like you said, well, the patient is there, and if you're recommending a biopsy, let's just do the biopsy then and there. But yes, and those points of those decisions of where do we go? Do we go B3? Do we go B4A? And it does, I think you bring up really relevant points. Does anyone else have any additional comments? We're getting towards the end here. There are a couple of people who've asked if there's a date to begin screening mammograms, and I think we addressed that early on, that there isn't. Everyone is different regionally. For those of you watching, I'm going to turn off my video because I hear a little bit of feedback. But I think we all know that we're just sort of flexing and adapting, as taking Dr. Brem's term there, as best as we can. There was one additional question of whether or not this material and this webinar will be shared in some format so they can share it with other people. I'll leave that to the organizers to jump in from CME to let us know where people can access the webinar video. Any closing comments from Phyllis, from you, or Dr. Brem? I'll start with you, Phyllis.
You know, we've been fighting the breast cancer fight together, many of us, for a long, long time. And I always look at things like this to be an opportunity to do it better. So that's the way I'm addressing this. How can we do it better? How can we do it safer? How can we do it well? How can we still provide quality medicine? And luckily, I work with a team every day who has those same goals. And I'm hoping collectively we can do that across the country. And as Dr. Brum said, don't step back, not now. We've worked too hard to get where we are now with breast cancer.
Dr. Brem.
Yeah, I just want to add that there are some upsides. I think, there really isn't any reason. I have a very long commute to work. There isn't any reason that you can't read screens from home. You can't read MRs from home with the right software. So I think we'll be more productive. I think that there have been some other, really positive things about this. For instance, for those of us who have residents, visiting professor used to be a big thing. People used to have to take a day off, travel sometimes more than a day if you're coming from a distance. And now we're each asking each other to educate our residents, give conferences from around the country, and whether it's residents or each other, the opportunity to really develop a library of web-based education, I think has expanded our horizons. The idea of greater efficiency with pre-registration, with waiting, I think we are looking at everything from a new perspective. So I think this has been like a hard stop and an opportunity for all of us to look at our practices and say, well, what are we doing well? What are we doing that we could do better? So do I wish that it never happened? Absolutely. Do I think that there are things we can take away from it? Yes. And when you do reopen, think about what you would want. What you would want your wife, your sister, your mother. And that's how we should be doing it now, because there is that opportunity as we rethink everything. We rethink workflow, we rethink triage, we rethink education. So all of that. And I think it's been a very steep learning curve for all of us. It's been very difficult. As Phyllis said, our lives have changed in every bit. I mean, for me personally, having had COVID very early on, gratefully early on, before the fear was quite as drastic as it is now. We've lost a couple of breast imagers in our country to COVID. So I think it's a restart and an opportunity to really rethink about everything in a fresh perspective.
Great. Yes. Thank you both. You've given us such great insights. Dr. Brem, who's at George Washington University, giving us somewhat of an academic perspective. Phyllis Falk, who at Imaging for Women, kind of giving us more of a community-based perspective. There's been a lot of people who've joined throughout the webinar asking, when will screening reopen? And I think the simple question is, we don't know. And it may be different state to state or region to region. And how you're using PPE or other types of materials to protect yourself will vary on the resources you have available to you, and also the type of center. Phyllis had given us some great examples of having people drive up and be able to phone in their car and register, whereas, from the center that Dr. Brem is at, that's not possible, but looking at how they use their mammography rooms differently, and then certainly when patients are in the room, whether they can do everything at once, meaning if they need supplemental imaging, biopsy, any of those things. But I thank you both. Those are really great insights, and you guys have shared some valuable time in a time that's stressful for all of us in trying to sort and navigate an unknown world. It's really an unknown frontier. And with that, I'll conclude the webinar. At the end, the world-class CME folks will come in and explain how they can share this webinar. So if you've enjoyed the webinar, we thank you, and you can share this with others to view at a later time. Thank you both, Dr. Brem. Thank you, Phyllis Falk, for joining us today.
Thank you.
Thank you.